We will start with our keynote address. A keynote address is done by Professor Anne-Beatrice Kihara. Professor Anne-Beatrice Kihara is the immediate past president of FIGO, the Federation of Obs-Gyn organization. That is, she was the president of all gynecologists in the world. She's a past president of KOGS, and she is also a champion of every woman, everywhere, every time. And she is also ran a clinic that previously saw many women in Nairobi. And a fun fact about Professor Anne-Beatrice Kihara is that spinal anesthesia in this country was started as a result of an example of spinal anesthesia administered at her clinic, Ruby. And this was taken up by the Ministry of Health, and now it's a normal phenomenon. With that, I would want to call upon Anne-Beatrice Kihara to give the keynote address for the KOGS Central Symposium 2026. Professor.
Thank you for this invite to the KOGS Congress in Nyeri. I would have loved to be with you, colleagues, friends, partners, but duty always seems to call me out. But I felt it is extremely important to really provide this keynote, and particularly in the context that we had the acceleration plan launch for every woman, every newborn, everywhere yesterday. And today I want to speak to you talking about every woman, every newborn, everywhere, and Fem-Tech. My name is Professor Anne-Beatrice Kihara, the immediate past president of FIGO, and also an ardent researcher and leader within our country. But let me start. I want to ask you a series of questions. How do you know you need to escalate care for a sick mother? Is it based on a high index of suspicion? The use of the Maternal Early Obstetric Warning Sign chart at triage? Or do you do predictive evaluation? Or address early warning signs and provision of, therefore, a robust referral system? Amongst our community health promoters, they're increasingly conducting rapid diagnostic tests. This detects biomarkers related to the omic sciences, namely epigenetics, biomarkers that we are picking out that really define certain diseases, or metabolomics or proteomics. And this is either being done as point of care with them in charge, or you are actually increasingly being asked to undertake self-care tests. What is the value of maternal perinatal death surveillance and response? This data today, and particularly now with inter-county MPDSRs going on, and with our Council of Governors paying more attention to our death surveillance and response, is it being captured in real time? And does it inform the delays or the predictors or the social determinants? And are we really getting the resilience of the health system and even addressing health economics as we undertake this exercise? Think on these things, and this will really give us a guidance onto our Fem-Tech. But let us also look at our current predicament. Official development assistance has gone down, with donors declining and in some cases decreasing exponentially what they provide us in terms of funding. Politically and socially, we are having curtailed access and equity of care. And this has not left out maternal newborn health. It also includes immunization. It includes our family planning. It includes our nutrition programs. So we must have a rethink, not just the provision of services, but how to provide them equitably and accessible to everybody, everywhere. Social cultural barriers, and particularly in maternal newborn health and women's health. To state a few, we still have adolescent pregnancy. We still have gender-based violence. We still have early marriages. We still have FGM. Gender-based research. And I want to take a step back and let us remember the Tuscany study that was done many, many years ago. It was a syphilitic study where people studied the stages of that particular disease amongst men. Nobody to date has ever looked back and asked, what happened to the women and what happened to the next generation from those kind of relationships? Information and service gaps, they still prevail. And I must mention, in our setting, a lot of our hospitals are still on manual data. How can we make decisions for resources, decisions for policy, decisions for advocacy, if we are not digitalized and particularly into real time? The other thing is fragmentation. We have medicine as medicine, isolated from other disciplines such as education, finance, agriculture, water and sanitation, architecture, information technology, research and innovations in women's health, the justice and governance system, and we hardly contextualize our health with the communities that we do serve. In fact, I want to challenge us as we speak. Are we putting them at the center of their own health and well-being? Or are we even advancing to co-creating with human-centered designs? What does this mean? With this fracturing, are we really going to attain sustainable development goals? I hardly think so. So we need to have a rethink how to approach our health. Look at these two graphs. Maternal mortality indicators. We still see sub-Saharan Africa at the top with the red line, despite the fact globally we are declining. The same for neonatal mortality rate. And my question to you is this: Sustainable Development Goals, maternal mortality should be less than 70 per 100,000 live births. Neonatal mortality should be less than 12 per 1,000 live births. Stillbirths should be less than 12 per 1,000 live births. Can we still continue on business as usual? Or should we now take the trajectory that was actually articulated to Kenyans yesterday? With the leadership that we have, both by the president of this nation and the cabinet secretary of health, they have said they want to be at the core of accelerating and catalyzing efforts in this nation towards reduction of maternal and newborn deaths. We need to ask ourselves in our respective counties, what should we do? Again, I do not want us to have a blanket statement. It should be informed by the digitalized data that gives context and priority agenda for each of our counties. But what then is every woman, every newborn, everywhere? What are the targets that I've already mentioned? And the milestones? 90% of every pregnant woman should have at least 4 antenatal contacts. But again, WHO has revised this to 8. And that is what our nation strives for. But we also know in our antenatal clinics, women will come once or twice. Now, 4 is a tall order. 8 is even a taller order. So what can we put in place to actually make sure? Can we think telemedicine, teleconsults, a hybrid way of participating with the women, group antenatal clinics where women can also collaboratively share? 90% of births must be underskilled attendants. But again, let's be real. In our maternity units, what is the ratio of the midwife to the number of patients, the workload to the workforce? What can we inject such that the critical patients are addressed And those other patients can actually be seen at lower levels. Should we rethink our modeling of care? It's not just about increasing the numbers of staff. It is the competence and the motivation to work. 80% should access emergency obstetric and newborn care. And here I want us to really think a little bit deeper. Majority of us are very familiar with the emergency obstetric and newborn care skills training and simulations that are being conducted on a regular basis. But how many of our institutions do have corners that continuously give this low dose, high frequency, impactful training? How many of us actually conduct on a regular basis the drills that are required? Let's think differently. Look at the airline industry. When you enter a plane, you're always told, even if you're a frequent flyer, please pay attention. Why can't we do the same for maternal and newborn health? Postnatal follow-through. Whether a woman delivers in the hospital or outside of the hospital, we're saying 80% must be seen within 48 hours of birth. Now, why is this? Postpartum hemorrhage, puerperal sepsis, fistulae formation. These are aspects that we would be able to pick out, including complications related with non-communicable diseases. So, are we actually seeing the patients? And it's not sight, it is actual clinical evaluation. And then we're saying, no matter what you do, if we do not address ourselves to social determinants, we will not make a difference. The education, the nutrition, the family planning, the bigger elements that also speak to multi-sector and the gender concerns, 65% to 80%. In this nation, we want to adopt an 80% so that we can actually begin to empower women with their health. At the bottom of this slide, you can see the 10 implementation milestones. Look at policies, look at investment, look at response and resilience. Address quality of care. Look at the human resource for health, the medical commodities and devices, data for action, equity, accountability, and research, innovation, and knowledge exchange. Again, on this slide, I won't belabor too much to it, but you will see that in each of these pillars, we have what do you do in normal contact and how do you manage complications arising. And as if this is not enough, we want to look at a continuum. It's not just antenatal. We start at preconception, antenatal, intrapartum, emergency care, postnatal. But for the child, we even want to go as far as child survival up to 5 years of age. Again, let us reflect, colleagues. What does SHA cover, both for essential and for emergency health packages? And where is your voice in the leadership towards this direction? What does every woman, every newborn, everywhere, and primary health care that this nation is really pushing for? It strengthens the community and primary level of services. It promotes skilled birth attendance, referral mechanisms, linkage into the health system, and even emergency obstetric care. It supports and aligns with the Kenya primary health coverage centered health reforms. In relation to universal health coverage, we're principally looking at lack of financial depletion of the individual woman and their families, but giving equity and access a sound grounding as we're doing so, targeting underserved and vulnerable populations. This is really what we aim to do in this nation. Yes, we've had several roadmaps, as you can see, accelerating interventions in our health planning, the Kenyan digital economy, subnational data analytics are all coming up. And today we now have every woman, every newborn, everywhere roadmap. This in our government strategy is termed as the 90-90, 80-80-80. But you cannot achieve EWENE without a multi-sectoral collaboration, which gives a holistic approach of women's health and not address only her reproduction. You must link health with education, nutrition, water and sanitation, infrastructure. Address gender inequities and social determinants, as stated before, and promote collaborations, particularly now between counties, increasing the number of collaborative partners and involving the communities. They must be engaged in the health conversation and support and resilience inclusive of the health system. So how do we put Fem-Tech with EWENE? First and foremost, digitalize, digitalize, digitalize. We have to move to real-time data. Why? It will influence our practice to be evidence-based practice. It will influence our policy. It will influence our advocacy. It will influence resource mobilization. Support telemedicine, mobile and teleconsultations in maternal newborn health. Promote AI-supported diagnostics and referral tracking, including the GPS mapping of hotspots within our counties. But we have to have all this with real-time data system, the electronic health system. What does it open up? It opens up digital antenatal, intrapartum, and postpartum tracking, SMS reminders for antenatal clinics. And for those of you in some of your counties, you already have Prompt as one of the major FEM technologies that are happening in there. And immunizations would be covered even better. Remote maternal monitoring using wearable technologies. And please note, wearable technologies are linked to the health system and not autonomously being managed by the women themselves. Community health workers and promoters really form the core primary health practitioners that will assist us on this journey. At the bottom of this slide, I have depicted the pillars for the acceleration plan as our investment case and also articulated in the EWENE targets and milestones. But we must also recognize the bias for women and gender, lack of equity and equality has had a major influence over the years. And you can see on this slide that ecosystem needs to change. Researchers, AI developers, clinicians, regulators, employers, patients, and the public need to recognize the investment case in women's health. Please note, you're not just dealing with the health of a woman, you're dealing with also the health of the next generation that matters. So how do we close the knowledge gap? No one should be left behind. We need to revise our legislative environment. And I'm pleased to tell you, this is something we are beginning to undertake by looking at the policy and regulatory environment with gender responsive lens. Evidence generation, and more so even disaggregating the data that we do receive when addressing women's health. Healthcare provider capacity building as innovators and also consumers of innovative products. Fem-Tech product profiling, and then market to scale. No one should be left behind. So we must include even those who are far-fetched, yet their need is greatest. We have a paper that we did write with the World Economic Forum on the prescription for change, where we are recommending health research and the policy environment for women to include the following pillars: innovation, inclusivity, a relook at data and even how we conduct clinical trials and how we design those clinical trials, and deepening our insights to gender and sex-specific issues. We note women are affected disproportionately by disease. In fact, the tabulation is 25% remain in ill health. Women are differently affected by disease, and women are even uniquely affected by disease. Men don't get pregnant. That's one uniqueness. Men don't get fibroids. They don't have endometriosis. They don't have menopause. These are specific to women. And this is where we talk about having the continuum of care when addressing women's health. Fem-Tech is not new. It was first coined in 2016 by Ida Tin. It has grown, but it's only now beginning to raise its head within our setup. It provides a wide range of solutions to improve healthcare for women across a number of female-specific conditions: menstrual health, pelvic and sexuality, fertility, menopause, contraception. Many innovators have hurdles from proof of concept to market readiness. So we need the programmatic push so that people do not face valleys of death with their innovations. We need to have public awareness, company formations, innovative hubs, and funding that is surging. On this slide, I depict the continuum and the life course approach to Fem-Tech, from adolescence to reproductive years to pregnancy to postpartum, perimenopause, and aging populations. I know a lot of you think when you think Fem-Tech, you think of ultrasound, but it's only one of those. Today, we're able to do point-of-care ultrasound, AI-assisted ultrasound, and even conduct telehealth so that remotely I am able to still see the scanned pictures. AI is even assisting us with reading those photo images and making good deductions that can predict the illness or the problems affiliated with either the mother and the baby. We're moving from simulation to date and beginning to adopt virtual reality, augmented reality, and mixed reality. So keep your heads up. These are issues that we are certainly bringing to vogue. So Fem-Tech is going to be a disruptor. We have self-testing when we're looking for cervical cancer. We have blood group and rhesus factor we're able to do. We have other rapid diagnostic tests. We're empowering women with wearable devices. So we're improving care delivery. We're enabling self-care. We're improving diagnostics. We're addressing stigmatized disease areas. And we're delivering culturally sensitive and providing tailored care. But all this, you must have interoperability of data sets and central intelligence system to give a holistic approach and to exchange and enhance data usage. Central intelligence aggregates data from multiple sources, uses AI and analytics for deeper insights, as mentioned earlier, and supports clinical and policy decisions. I've listed here some of those data sources: electronic monitoring system, mobile health apps, community health platforms, lab, financial platforms. So the architecture of integration is also going to wake up and grow. API and health information exchange, cloud-based data warehousing, AI-driven dashboards. But I want to pause a little bit and talk about ideation. When you have that light bulb moment and you come up with an innovation, so that's your creativity, and you generate from an idea to solving a problem, generating a prototype. But that prototype is in infancy. It must have constant iterative learning to move it from a prototype of minimal fidelity to high fidelity. And even when you test it in the market, originally you will do what we call beta testing. From the beta testing, you introduce it into the clinical arena, where you now generate evidence that will validate that this should move on or discredit it. And this cascade now looks at the market intelligence for that given product. When finally it is taken and seen to be of use within our communities, then you now take it up and scale readiness for that particular product. Human-centered designs are increasingly being the way to go. You cannot introduce innovations without working and co-creating with the communities. They know their problems, they know what they need, and we must collaboratively work with that problem. Number two, it gives them ownership of those devices or those apps or those softwares that you want to introduce to them. And they have a more friendlier user experience. All of this geared towards quality of care. Then we have the pathway that we must follow. You have the product, whether it is a software or whether it's a wearable device or rapid diagnostic test or vaccine. You have the regulatory bodies, Pharmacy and Poisons Board, the Digital Health Act comes to play, data protection comes to play. And you cannot run away from that policy and regulatory environment. As I said earlier, you have the beta testing, you have the validation, acceptability. All this is evaluated through research. And once you have the evidence, then we are supposed to submit a dossier to the Ministry of Health, so that we now have the Ministry of Health taking on leadership on the Fem-Tech Observatory. It's not bringing in innovations or creating innovations as we would want them to happen for us. You have to constantly have them relooked at over periods of time. So what's the strategic policy significance? It operationalizes primary health coverage and universal health coverage reforms. Fem-Tech is disruptive and accelerates reduction of maternal and neonatal morbidity and mortality. It is certainly aligns with Sustainable Development Goals and the Every Newborn Action Plan and Ending Preventable Maternal Mortality frameworks. And it will therefore position Kenya as a leader in women-centered digital health innovation. Here I'm depicting different disciplines must come together. We cannot work alone if we're to really achieve SDGs as they are fast tracking for 2030. I have just taken an example, which I feel very important for all of us. As you begin to innovate and as you begin to work as interdisciplinaries and intersectors, this is what you will expect to see. As you're dealing with maternal menstrual health, as you're dealing with genetics, as you're dealing with reproduction, as you're dealing with menopause, just look at the armamentarium of an ecosystem that will bring you collaborative partnerships. It's not rocket science, ladies and gentlemen. Innovative hubs will definitely bring partnerships. Partnerships will bring resources, and we can then strengthen even the quality of care we provide our women and the outcomes, because that really is what we want to focus on as we continue to partner together. From the product ideation to the market, I've talked about the research and the validation. But in market research, we must also be aware of competitive analytics, industry reports, and key research, and even track with the Google Trends. Let's take something we all know, M-Pesa. It started here in Kenya. Today, it's flourishing above even most of those MasterCards and everything else that has come in as fintech. Why? It is the way it gained entry. It was the competitiveness, it was the accessibility, it was the lack of having inequity as we cascaded M-Pesa. How much more should we be doing then for women's health and Fem-Tech? Market validation. This is really where the market says, yes, we need this, and really puts it in its right place. So that would then bring it to scale. Effective health interventions at scale, investigations of the optimal way to expand programs. So again, will SHA adopt this? Can we make sure that we have essential and emergency health service delivery, that innovations become part of and not a unique entity? The systematic use of evidence in all forms for decision-making throughout the processes, and the scale readiness index moving beyond that initial prototype to early adopters to achieve widespread adoption, clinical integration, and sustained market impact. I want to end with this slide, which really shows you the interface of EWENE and Fem-Tech. Our priorities for EWENE: healthy women, healthy newborns, equity, quality of care, data, and accountability. On the Fem-Tech side, digital antenatal care, remote monitoring, AI and decision support, telehealth and e-consultations, emergency alerts and referrals, women-centered apps, digital health records. Now bring those together. And we always say you're stronger together than apart. We certainly will then have enablers of digital health infrastructure, data privacy, policy and standards, partnerships, and an ecosystem moving in that direction, capacity and innovation. Ladies and gentlemen, the collective impact: reduction of maternal mortality, reduction of newborn mortality, reduction of stillbirths, stronger health systems, stronger economies, newer markets. Women are able to be productive and participate as an empowered lady and as an empowered mother within the household, cascading to the nation. Lastly, you may be having medical students. You may be having teams within your hospitals. We are hoping to conduct a call to actually conduct training of healthcare providers as a series of weekend modular training so that people are more endowed with what is really the Fem-Tech ecosystem for Kenya. Taking on a life course, taking on gender-sensitive research, Fem-Tech digital tools, policy, and innovative skilling. We need a strong foundation. Please walk with us as we undertake to do this. Thank you very much. And I really want to thank Dr. Kigondu for giving me this opportunity to have a word or two with you. Thank you.